Welcome, everyone. Thank you so much for joining us tonight. And we are going to be talking about suicide. It is one of the most important topics that we can be discussing if you're a clinician. If you've been doing this work, whether you're brand new or have been doing it for a very long time, I am 100% certain that this topic has come up in your work. So what better way to be able to support our clients than to have discussions about supporting clinicians and topics around suicide. So I am joined with a fabulous panel who has done amazing work in the field, and I will introduce each one to you. But before I do, I just want to make sure that as we talk about this very hard-hitting topic, that each person does themselves a solid, and please make sure you take care of yourselves. Talking about suicide can be triggering, especially if you've had your own history with suicide or are struggling with your own mental health concerns at this time. So if at any time you're feeling like you need space, it is okay to step away from the video and come back, or if it feels very triggering and you want to share, please definitely make use of the chat. It is a great tool to connect with other clinicians who have had similar experiences or just have questions or thoughts about anything that we're discussing during the presentation. So definitely feel free to connect and use the chat and ask questions. Definitely respond to the polls, but also make sure, most importantly, make sure you're taking care of yourself. So without further ado, I am going to be introducing our speakers for this evening, and in no particular order on your screen, I wanted to talk about who we have joining us in this discussion. So tonight we are joined by Dr. Bart Andrews, who is a licensed psychologist and the Vice President of the Telehealth and Home Community Services Behavioral Health Response, or BHR. Dr. Andrews is a Senior Applied Suicide Intervention Skills Training trainer, assist for short. Forgive me, it's end of day, so I am working on making sure I'm eloquent and comprehensible. Thank you. Dr. Andrews has been an instructor for the St. Louis County Police Department Crisis Intervention Team and is a nationally recognized program. He is no stranger to discussions on hot topics such as suicide, so he's going to be joining us to further our understanding and come up with ways of thinking about suicide that can really support our clients. We're also going to be joined by Dr. Lisa Firestone. Dr. Lisa Firestone is the Director of Research and Education at the Glendon Association, and she's the Senior Editor for the mental health website psychalive.org. So if you do not have this listed as one of your resources, please make sure you go ahead and bookmark it now. She's the author of several books, including Conquer Your Own Critical Inner Voice, Creating a Life of Meaning and Compassion, and her most recent book, The Self Under Siege. So definitely Dr. Firestone has quite a bit of experience, and she's going to be chiming in on many of the questions as well. We're also joined by Dr. Scott Zeller. Dr. Scott Zeller is a psychiatrist and is the president of the acute psychiatry at Vituity, a professor at 2 medical schools, and past president of both the American Association for Emergency Psychiatry and the National Coalition on Psychiatric Emergencies. He was also the former chief psychiatric emergency services coordinator for Oakland. And I apologize, Dr. Zeller, if I misstated that. He definitely, and I also want to underscore that given COVID, we're doing a lot of work in telepsychiatry, telehealth, teleservices. He definitely is no stranger to doing work remotely, as Dr. Zeller has done lectures internationally as a keynote speaker and is known as the co-inventor of on-demand emergency telepsychiatry, which is much needed right now in this time, given that we are all seeing clients to some degree remotely. And last but not least, we have Dr. April Foreman, who is joining us. She is a licensed psychologist serving veterans as a clinical outreach specialist and is an executive committee I apologize for that, Dr. Foreman. You are an executive committee member of the board of American Association of Suicidology. I did it.
I know. And I think I got promoted since I sent you the bio, which is crazy. But like, I'm a suicidologist and psychologist. I think that's fair, wouldn't you say?
I think so. But I also want to highlight that you are the recipient of the Roger J. Tierney Award for your work as a founder and moderator of the first sponsored mental health chat on Twitter. I mean, where did we find out about a lot of issues with mental health? Sometimes not in the therapy room, it's online. So without further ado, let's jump into some questions. And if there's anything that anybody wants to throw in that I may have missed, feel free. But I usually like to start with, how are you all doing and how are you taking care of yourselves?
I think I would like for Bart to sort of chime in. I had quite a summer, and so it's pandemic, and my work has had a lot of rapid shifts that you wouldn't normally have. So we're working some long hours, teleworking, so not traveling all the time, but like at my house. I had a surgery and I was already exhausted, like this pandemic thing is. And so I actually, for the first time ever, and Bart and I do how many trainings and speaking engagements together for how many years?
I can't count them all, but it's been five, almost 6 years, April.
And I had to call Bart. I was at like a regular old training. We were talking about being clinician survivors of suicide loss. And so someone shared a story, and I just started bawling, which I don't know that that's ever happened to me in a training before, or when I was giving or receiving. And I had to call Bart actually because I had to do a podcast, like I had to get my act together quick. And Bart, it was rough. And that was one of the things that I learned, which is how I'm a person with a lot of energy and capacity and a lot of comfort with this topic. And I was worn out, and I would really encourage folks who are listening to take care of themselves. I didn't know how far out I'd gone with my energy.
I appreciate that. And Bart, you were going to chime in. How are you doing during this time?
I think it's been horrible. I'm not going to really lie about that. What an interesting 6 months. I actually was in Alaska right before COVID hit and didn't know if I was going to get back in, if they were going to shut everything down. I developed gout and ulcers right at the beginning of COVID, so couldn't eat, couldn't walk, and we were managing the pandemic. So it was a really interesting time. I will tell you that there was a great article just released about this idea of concept of surge capacity. Mm-hmm. And that in a crisis, we really have this reservoir that we pull on. But that's supposed to be short term, right? That's supposed to be something that at a certain amount of time, the crisis is over and you kind of have a recovery phase and then you move on. Well, there's no recovery phase here, right? This thing keeps unfolding in really interesting ways. You throw in the racial issues going on in our country and the things going on with police and political. And I can tell you, we've had at our agency, we've had one suicide of a staff member since COVID started. We've had a second death. Mm-hmm. And our clinicians have, and we deal with that at my agency. We deal with that very openly. We talk about that. We lean into that. But I can tell you it's been hard for me. One of the best things, I have to work out every day. First of all, if I don't work out every day, I'm lost.
Wait, but you're going to give us. I'm assuming you're jumping into some really good recommendations on how to take care of ourselves. And I don't want you to give away too much good information just yet.
I think really providing guidance to each other is a good way to take care of ourselves. Just like that. That was great. So one of the things that is really important is I've got, in April as part of this network, I got a chat group of 4 suicide experts. We're in contact every single day. Nice. And I can tell you that reservoir and that network of support and being able, when things are going bad, just be able to text with them back and forth, it really does keep me sane. So for folks that have a network, lean on your network, because there's times when I absolutely need it, where I'm just not going to be okay if I can't reach out and get that support.
I really appreciate you both sharing the impact that this time has had. And I want to make sure we have time to get to both Dr. Zeller and Dr. Firestone as well. Just share with us, how are you guys doing in this time?
Well, I can jump in. It's been very interesting because you were kind enough to mention that we had been the ones who really kind of pioneered emergency telepsychiatry 20 years ago. But I'd still been mostly seeing patients in person up until COVID hit. And I've been doing exclusively consults to ERs and inpatient wards in hospitals via telemedicine for the last 6 months or so. I'm immunocompromised because I have multiple myeloma, which is a bone marrow cancer, and so the hospital won't let me go in even though I want to. So it's been an interesting time to actually see how well this technology works, and here we are all meeting together on it, and it's really amazing how well it lends itself to psychology, psychotherapy, all these things where we can look each other eye to eye and talk about things. And it's fortunate we have something like this at this time, that we can still connect with individuals and work with each other. And the high definition is good enough so that we can even see if somebody's having a tremor, if there's their pupils are dilated. You can actually even tell things like that. So it's not like we're abdominal surgeons. We can actually do this over video. Right. So there's a nice benefit out of that. On the other hand, I'm very concerned about all this isolation, what this is doing to people. We know that suicide attempts are way, way up. There's the hospital that's closest to me that I see some patients in. According to a trauma surgeon there, their number of suicide attempts they're seeing is up like an order of magnitude over the past 6 months, which is crazy. I mean, 10 times more than what they're used to seeing. And I think that's something that is very meaningful to everybody who's on this call, and realizing that there's a lot out there that we're not seeing. As much as we're able to do and intervene by this new technology, there's a lot of people who are really isolated. There's a lot of people who are very sad, who are having bad things happen to them, and they have no one they can share it with. And I think it's really important for us to reach out and find those people that sometimes are maybe kind of off camera, if you will. And it's a really important time for that.
Great point. I mean, I think this is so important. It's accessibility. While, yes, we can see people on screen, we also have to remember we have to get the person on screen. And sometimes people don't always want to come and talk about themselves and their feelings. But I want to make sure I give space for Dr. Firestone, and then we'll jump into a round of questions.
Well, just like everyone has said, this has been a challenging time. I was seeing some clients remotely, but now I'm seeing all my clients remotely and have been since this pandemic started. We have elderly and frail family members, so we're being incredibly careful. So we've just been in one place, which I also usually travel a lot and do a lot of trainings, and would have been at the American Association of Suicidology conference. Had there not been a pandemic, we did attend virtually, but it's just been having to switch everything, and it is very different. I do like Dr. Zeller said, you can really connect with people face to face, and I do appreciate that. And in some ways, it makes therapy more intense, in a way, even than it might be in the consulting room. But it's it's different, and I am missing that. But I think this is the way we're going to be doing things for quite a while. So. Trying to make those adjustments.
Yes, and that's what this period has been about, adjustment and flexibility. And I want to just start with how much I appreciate everyone's candid responses, particularly because in this topic and just in therapy in general and in society in general, people don't always start with how many challenges they're experiencing. We always hear like, how are you doing? And the common response is, I'm fine, or I'm good. And so there's a lot that doesn't get spoken. And we're going to be talking about a heavy hitting topic. So being honest, being really open about experiences, I think is the first step. And I'm actually really curious with, the fact that we're doing this. I'm wondering, how did you all get into this field? Like, what led you to wanting to do work in suicidology? And Dr. Foreman, I'm going to start with you, and I'm curious about your interests.
So I was studying positive psychology for my dissertation. I was going to be a professor, and I love training graduate students. It was great fun. And I had to move back home to rural Kansas, where I'm from and my husband is from, for family reasons, very quickly. And I took the only job that you could have there, because I would have gone nuts without it, which was working in community mental health on a like basically a food stamp wage. If my husband had not been employed, I would have qualified for food stamps, what they paid me. And I show up and I'm like, I've got this. This is what the standard of care is and what I train people to do. And I show up and I'm like, oh, you don't get the standard of care. I was like, oh my goodness. And then there were like this whole group of folks who largely were diagnosed with borderline personality disorder, which I didn't realize at the time, but that's 3 to 10% of those folks die by suicide. That's like if you went to your primary care doctor and he said, listen, you've got this disease where everyone's going to hate you and about 1 out of 10 times is going to kill you, you would take it super seriously. But everyone, like these patients were the butt of everyone's joke. They weren't get well. Eventually, 2 of the folks on my caseload were 2 of the most expensive outpatient folks in the state, like high frequency service. And I thought, there's got to be something better than this. And a lot of things happened, but mostly what I found out because of Twitter was I could literally just talk to the most important experts in my field. And so I started with like a tweet to Marshall and Ann. Turned out she wasn't running her own Twitter account, and she and I found that out together in an interesting, experience in a hallway. But and I was like, we're going to start a DBT clinic. You're going to learn how to do this, whatever. And we set that up, and then it just kept happening. It turned out I cared about this, and it turned out, and I didn't know I would feel this way because I was going to do optimal graduate students and high functioning folks. And it turned out that once I realized that this was the leading cause of death in the United States, and until COVID, the 10th leading cause of death, and that we absolutely did not have solutions that would work at scale for what kills people. And we only have a few like well understood, evidence-based solutions. And Bart will argue with me about this, but there's really only kind of 3 basic approaches. And people can't access the care. And if everybody who needed the care tried to access the care, you'd have a massive shortage of licensed clinicians. And 9 out of 10 of those aren't trained properly. And I was one of them, never appropriately trained in graduate school. I'm sorry, folks. I loved my supervisors, but like really wasn't. And I was like, oh, if there is a social justice issue that mattered to me, that I stood right in the middle of, it was that. And here we are, right?
So you found yourself in the right place, essentially at the right time, despite the circumstances. You were able to create an opportunity to provide this service and then expand. So that sounds amazing. Maybe it wasn't planned in that way, but it happened that way.
It was just like, oh my gosh, like, oh, and I kept looking for the person who really knew the answer and who really was going to fix it. And it really, I was like, oh, it's turtles all the way down. And so here we are.
Yeah. And how about for you, Dr. Firestone? What led you to joining the field of suicidology?
Well, a couple of things. The first was that my very first patient when I was in graduate school had made 6 prior attempts, 3 in the hospital. I got very focused on learning as much as I could about this issue really quickly. And my supervisors, like Dr. Foreman just said, were, sort of like, didn't have a lot to offer and were not very helpful. And it was really difficult, I also got into the field because when I was doing my dissertation, the person who started the Glendon Association, a man named Frank Tobey, happened to fly on an airplane back from Washington, D.C., sitting next to then Surgeon General C. Everett Koop, who said, we need an assessment for suicide risk. And I was like, yeah, we do. So anyhow, that's what I ended up starting to work on. And so anyhow, those 2 things really got my attention. And it's such an important field, and so many people come out of school not well trained and not comfortable actually with dealing with people who are really struggling, and they really need the help.
Well, one thing that you spoke to, oh, sorry about that. Go ahead. I was just noticing one thing that both of you spoke to is about the lack of training and the lack of understanding. And I I'm hoping that you guys can speak to some of the like just baseline knowledge about suicide, because I think there are a lot of misconceptions that are floating out there. And Dr. Zeller, if you can start us off and tell us what you think some of the baseline, like the warning signs, the risks, et cetera, the things that clinicians really need to know.
Yeah, it's a great question. And actually, if I can go back a little bit to how we got into this experience, I'm now in my 35th year of doing emergency psychiatry, and I used to be in charge of a site that was seeing 20,000 involuntary psychiatric hold patients per year. And the great majority of those were there for reasons of danger to self or suicidality. And so I've seen probably tens of thousands of people after suicide attempts who are having acute suicide attempts. And when you have when you've seen all those many things, up to some really like gut-wrenching suicide attempts, up to people scratching a wrist with a paperclip, but they're all suicidality. And what's driving this? And what's making people think that they don't want to take another breath on this earth, and thinking that there's something better out of death. And that's what drove me to want to learn more and really get more involved in this. And I think that goes into your question, which is what are the warning signs? What do you need to look for? And I will second my colleagues here who said that it's really unfortunate that there's so little training in this, and there's really so unfortunate there's so little acuity and emergency care training depending on no matter where you are in the mental health spectrum in terms of the professional avenue. And it's annoying, and it really makes me angry sometimes, because even so, me being a psychiatrist, my organization is the American Psychiatric Association. They put such a small, low priority on acute psychiatry, and there's like, no, what's really important to us is our outpatient practices, and we don't really want to learn about that other stuff, and why don't you go to the emergency medicine conference instead? I mean, that's seriously their response when they have the big APA conference each year. They're not really interested anymore in talking about inpatient psychiatry or emergency psychiatry or suicide. So I think that unfortunately we're not seeing a pathway to more education about this, and maybe even we can start this tonight saying, like, why aren't we doing more about this? This is our heart attacks. This is our car accidents. This is our homicides. We need to be the ones that are saying, like, these are preventable deaths. Nobody needs to kill themselves. We can do something to help the vast majority of these people. There's no reason they have to kill themselves. So going back to your original question, I'm sorry for my digression.
No problem. And I think part of that is part of, thinking about that and leading into the original question is often in my work, in my experience, I have heard people saying, but he didn't seem depressed, or she seemed fine. I would never have thought that they were suicidal. And so and sometimes these are coming from folks who are in the field. Other times it's family, and sometimes it's neighbors. It's the reality is, I don't think that people, despite how much information you can Google, I still don't think people really have a fair grounding of what some of the warning signs and risks are that they should be looking for.
Yeah, it's a great question. And also you're absolutely right, because if you're looking somebody in the face and saying, are you suicidal? Or, they can very easily go, nah, what are you talking about? I'd never do anything like that. And that can that can smoke screen some people, and especially if you're not used to dealing with suicidal people. So what are some of those other warning signs you should look for? Sometimes there's subtle things, but you can find it. There's nothing more important than collateral information when you're doing a suicide evaluation on somebody. If they're saying, I'm fine, I don't know what you're talking about, that mom caught me, I just accidentally slipped my wrist 3 times. It had nothing to do with suicidality, but you find that there's some kind of very common themes that somebody who's very serious about suicide do, such as they make sure that somebody is taking care of their pets. Mm-hmm. If you hear about anybody who's gone to their neighbors saying, if anything happens to me, could you take care of Rover? That's a really scary warning sign, actually. That means they really have come to peace with their going to kill themselves, and they are already making plans for everything. If they're giving away treasured items, those are things to be real concerned about. You hear those kind of things, it's much scarier than hearing somebody who you're hearing, oh, he every time he gets drunk, he talks about suicide. Obviously, that's very scary too, but that can be something that's almost like a trait in some people, and they never actually do anything. Obviously, any hint of suicide you need to explore, and I'm not saying that anyone is less of concern than the others, but there's some of these things that are beyond what we even see that we need to learn more about, and maybe it's good to ask questions about, is your rent paid? Somebody may not pay their rent for next month because they figure they're not going to be alive. They don't have to worry about it. Some of these characteristics are really compelling, and those are the people that are going to actually go forward and complete a suicide. And those are the ones you need to be most concerned about. Suicide attempts, we know from different groups, teenagers make 100 suicide attempts for every one completion. Whereas the older you get, there's more completions per attempt, up until you get to the point where people are in their 70s and 80s, it's like 3 to 1. And it's very, very common. Those are the ones who do all those kind of planning and really decide, and they think this is the solution to everything, and that's where you need to find out. I'm sorry for taking hold of it.
I think it's super important, and I'm sure we can spend days talking about this topic to make sure that people are fully aware of what they need to be looking out for. And that's the thing that you were pointing out. There's not enough training, and Dr. Foreman, you were also pointing out there's not enough training, and it's not only is there not enough training, but there's not enough science. So when Dr. Zeller is talking about using his clinical experience, and that's what we really rely on, people who just have a lot of clinical experience. And thank God we have people like emergency physicians who see enough volume that this doesn't feel scary or rare. But when we look at the research on this, this was a lie we told the public. This was a public health campaign, that there are warning signs and there's a set and you can know what they are. Right. That was a very intentionally crafted thing. Like, on the committees that craft those things, I love you people, you're wonderful, but we all know that. We know that for AAS, where Bart and I are on the board, we sponsored the flagship journal in suicide, life-threatening behavior. We know all the scientists. We are here to tell you that if you are taught how to do a suicide risk assessment, which I was never taught, you're still miles ahead. But even our best suicide risk assessments, like if you did the Columbia, and I know Kelly Posner, she's great, the Angelica Houston of suicidology, gorgeous and brilliant. But the statistical likelihood that you're going to be accurate it's like a flip of a coin. And we give clinicians, first of all, not enough training. We don't require the training in almost any states, except for I think now recently sort of 2. And then we almost don't fund the science at all, so we don't get any better at this. And so we expect you, the therapists and clinicians, to take responsibility for whether or not you've assessed somebody correctly without having given you the science to do it. And that I said, this isn't just unfortunate, because Dr. Zeller, I know you are a modulated person. I'm a little bit more effervescent. I would say it is unjust that when you look at how little we fund things, when you look at how little we train people, but how many people die, and for those who don't die, who live in excruciating pain, it's just wrong. And Bart, I'll let you go after it.
Yeah, well, yeah. You're effervescent. I'm downright bitter. I would say that our approach to suicide in this country has been grossly unethical. We literally have made it okay for clinicians to practice and not be adequately trained in how to screen or treat suicide.
Can I throw in a question really quickly about that?
April,
would you say that the efforts of the APA, American Psychological Association, in the recent years in terms of requiring suicide training as a CE requirement is making a step in the right direction?
I don't know the extent. I know there's only one state that requires psychologists in training to get suicide intervention training, and that's California. So I'm not sure what the APA's done exactly, but they certainly haven't said. April, maybe you know more. Have they said that if you're
we do have friends at the APA, like?
Well, I don't. we can be friendly and disagree, I hope, but maybe not anymore in our new age. But I can tell you this, I don't think the APA has put out a statement that's saying all APA accredited psychology programs need to have a robust suicide intervention training program.
Right.
I may have missed that. APA, anybody on the APA want to comment on that? I'm glad to have a public conversation about that.
Well, I imagine we might see changes given COVID, and I'm sure you can add to this too. Like, I'm wondering if the suicide rates have increased since COVID.
No. We're gonna put a kibosh on that right away. So some really important things we need to talk about. One, to date, it looks like the suicide rate has at best stayed the same or dropped dramatically. Colorado has a rolling 3-month rate. They showed a marked reduction in March, April, and into May. In fact, all the research and data suggests we should experience a decrease in suicide right now, not an increase, right? Missouri preliminary data, we're not seeing an increase. My crisis line saw a marked reduction in suicide-related calls. And in fact, there was a big story out of Oakland about this increased number of suicides in an ED, and that story was recanted. They pulled it back because it turned out not to be accurate. Yeah, that was a deep.
I didn't hear the recant. Yeah, so you're talking about suicides or suicide attempts or suicidality? You're finding
let's talk
completed suicides.
We have really bad data, horrible data, and there's but the data that we do have at this point is not suggesting there's an increase. And in fact, the research on suicide post-disaster tends to show marked reductions in suicide, not increases. Now, there's a few exceptions.
Hold on, Dr. Foreman. 1 second.
You're chomping at the bit here. Get in here. What do you got?
So California, I actually talked with some reporters in California because they reach out to the AAS with exactly those numbers, and they ask about attempts and deaths. And there is another public myth, which is that we're counting it and we can just tell you like we can with COVID. We're not. We could if we wanted to. There was until a few months ago 6 people at the CDC, like Sesame Street 6, who were counting all this stuff. Takes them 2 years to get the numbers out. They got excited because we've been talking about them on blast in the news for a couple of years, and we love them. Like, we work with the suicidologists, but now there's here we go, 9. There are 9 folks. And we don't know that, but I have heard from the California Emergency Department. So reporters were calling us from California saying that attempts are up. When we're looking at data, there's some really cool data stuff that Bart's also involved with that looks at the social media accounts, so they can do some interesting language analysis. And they think suicide risk for the population is up, and attempts may be up, and it may be regional. So what happens in California, Colorado, Louisiana, or Wisconsin may be very different, but we're treating it like it's like one nation, but we haven't been impacted the same.
Well, can I add to just the information that's on the CDC? I think the latest stats are from 2016. And so there was, steep increases in terms of the amounts of suicides and attempts. So I'm just thinking that was 4 years ago. So if you're a clinician like me and you want to get data, where would be the best place to go?
Mm-hmm.
That's a great question. AFSP and AAS put out the most recent CDC data, and there's I think isn't 18 data's out. So I think 18 data. But let this sink in just for a minute. It's halfway through 2020, and we don't have even 2019 data readily available. Now, Missouri does. I will tell you, Missouri got preliminary data for 2019, and our suicide rate was down for 2019. But one of the challenges that we have is you can see a friend of mine, Kim Walton, who's also part of the Zero Suicide Academy, she talks about we measure what we care about, right? We care about COVID to a certain extent. We care about in Missouri, there are literally digital billboards that have real-time, up-to-date accident fatality data. You literally can be driving down Highway 70 between St. Louis and Kansas City, and there's a sign that flashes the up-to-date number of traffic fatalities. We can't even get suicide data for the last couple of months in an accurate way. And we've got no decent tracking system for suicide attempts that anybody is going to agree on. Now, April pointed out a really interesting thing that I want to hit home because she and I disagree on this 100%. There is an increase in survey data of people being depressed and anxious. Not going to dispute it. right? But keep in mind, the link between depression and anxiety and suicide is weak at best. And two, we know that everybody's going through this at the same time. We're seeing a very normal response to really crappy events. And we saw this post 9/11 as well, right? People do get stressed out and they're anxious and they're depressed, but it's normalized. Everybody is. There's good reason why everybody's feeling it with it. They can look out and they can explain how they're feeling in the world around them.
But what do you say about the people who are depressed and anxious, but also expressing suicidal ideation from that same CDC survey? So it's not just depressed and anxious, but they talk about suicide. 25% of 18 to 24-year-olds.
Yeah, and do we know what the rate is? It up or more youth attempting? Where's that data?
But I think you're right when you say we're only counting what we're interested in right now. So everybody's so focused on COVID infections and deaths. Maybe a suicide is another COVID-related death for all we know. You know, they're just really focusing on one area right now, and the suicide is like the dirty secret, and anxiety and all the mental health impacts are kind of buried in the background because everything's so focused in this one direction right now, and that's what my concern is.
Have I got a deal for you, Scott? So when they're looking at Bart and I've worked with some data scientists over the years. That was part of our Twitter chat that we did, hooked us up with all these fun people, right? And one of the things that they can do now is measure suicide risk and like overall mental wellness by like using public social media accounts and tell you like what's happening in a population. And Scott, they're looking at suicidality and mental wellness, and they did look at that, and they can even do it like on a day-by-day basis, and it just like tanked. So Scott,
I'm curious with that, Dr. Foreman, if you could also, and this is open too, and I want to make sure we get Dr. Firestone in there and get her thoughts. I am wondering, just in terms of your work, in terms of the data, we know that suicide is not just a national problem, it's an international problem. People of all walks of life are overwhelmed and have been, taking their lives or, have attempted. And I'm wondering, this is kind of like a multi-part question, if there have been increased risks with certain ethnic groups or decreases amongst certain ethnic groups. And since we're all at home and the hashtag BLM, Black Lives Matter movement, has there been an increase or a decrease? So I'm just wondering, like, if we look at through a cultural lens, are we seeing increases or decreases in
We've
suicide?
got that data too. So they looked, so this data, it's so funny, and I don't think we can pop it on the screen, but we looked at suicide risk, like sort of when the pandemic started. And then we looked at like when people started to feel better. And then after the death of George Floyd, and the sort of great awakening, we saw a change as well. And by we, I really want to thank the good people at Quantify. Our board chair at AAS works there in that data science company, but something is happening. It's crazy that you could, Bart and Scott are saying, we could be measuring this. You know, there's going to give a shizzle.
Well, and I think it's a matter of figuring out how to, empower clinicians across the board. Because what we find is when something is important, there's a small group who are pushing this thing forward, and we need to help empower people to be able to, as a large group, as both APAs, the American Psychological Association, as well as the Social Work Association and Marriage and Family Therapy Associations, to say this is a need. And I'm wondering about the training. Once training is put in place where people feel a little more confident in doing suicide risk assessments, can we embolden, empower people to request that this be something that's part of training programs, that's part of ongoing training for licensed clinicians? But I think first we have to start with just people doing the risk assessments. And I'm wondering if, Dr. Foreman, if you can jump on two questions. Doing the risk assessment, what are some of the best ways to do it and important nuances to remember? But also, I'm curious, I'm going to start with that question, and then we'll come back to the second question that I have.
Can I actually jump right in before she answers this? Because I'm sorry, don't be.
You've done way more risk assessments than me. I bet you anything.
No, here's the point, because you brought up something before, which I think is very valid, is that most of those paper risk assessments aren't really worth the cost of the paper they're printed on. And so, although we're doing those now, that the Joint Commission is requiring them, and CMS, all these things, they're saying, oh, risk assessments. The ones that are just like check boxes aren't really helping. We're doing them, and that might help push people towards clinicians who can do those risk assessments. But what I'd like to see, and maybe April would agree with me on this, is people trained to do an actual risk assessment where they're doing a face-to-face evaluation and doing the best they can by a clinical interview to try to do things much better than, oh, you got an 18 out of 32. You're going to kill yourself. You have to go to the hospital.
I think that's the question, right? So it's not what risk assessment form.
So I'm sorry for jumping.
I totally, I understand.
I'm going to say that first of all, you should be trained about the topic of suicide. Like you could tell me about what the signs of a heart attack are. That does not make me a cardiologist, for the love of muffins. And so you absolutely should train people. Bart believes in universal screening. I have different feelings about that. Scott, you and Bart are going to like wrestle, and I'm going to eat popcorn.
I don't mind universal screening because that at least points people in a direction. If you're using like those two parts of the Columbia, that's okay. But using it as the sole director of how people are going to go to the next level is where I have a problem.
Well, I think too, if we're talking about different disciplines, we have psychologists and we have a psychiatrist. And I know for psychologists who are trained, we shouldn't be using one single tool to diagnose anything. So in thinking about best ways of like actually assessing someone for risk, what would that best way be? Would it be a simple interview? Would it be the interview plus let me reach out to your family and reach out to your neighbors? And is it going to take 20 minutes? Is it going to take 4 hours? Like, what do you guys think?
Well, let's separate some things out that are really important. One, how we train or work with the community on prevent suicide is going to look very different than what we do in healthcare. So one of the things that we need to do in healthcare, and this is just, we don't even have a good solid standard agreed upon level of care for suicide, right? If you look at heart disease, if you look at diabetes, if you look at all sorts of things, there's a real clear standard of care. Everybody's pretty much on the same page, right? You're going to get very similar treatment wherever you go. We don't have anything approaching that in suicide, and that's unethical. So in terms of risk, I'll say this. I think we need to get away until we have really good risk prediction tools, and we don't have them, by the way, we simply don't. What we have are screeners and clinical judgment, right? So what I'll say about this, and this is my new talking point. We need to quit talking about risk and talk about need. And we need to talk about identifying needs and treating needs. Suicide thoughts are treatable. To treat them, we need to identify them. So we need to do a couple of different things. One, we need to have an agreed upon screening process. I'm all for universal screening, April, if there's good care pathways following that screening. I think that for me, and when people push back on universal screening, I do agree. If you do universal screening and do something like Scott's saying and just plug people in the hospital. By the way, you want to talk about risk factors? Being admitted to a hospital for psychiatric purposes or for suicide is the biggest risk factor we know about for suicide death, right? So Scott Zeller's psychiatric emergency system approach and get people out of the hospital, keep them, treat them where they are. You're a hero, Scott. It's wonderful. But this is really important too. You address the need and then you treat. April was really kind, saying 10% of healthcare professionals or therapists are adequately trained. I'm going to say it's probably not that high. And two, we need to make sure that people, when they do talk about suicide, that we take the fear of hospitalization off the table as much as we possibly can. Because one of the things that happens is people talk about suicide and the clinician freaks out because we've got, boy, if you had to sit in, I'm going to say this, if you had to sit on the average therapy session, particularly around suicide going around the country, you'd be horrified because it's not good care, y'all. It's just not, right? Make sure that folks know that the hospitalization is a last resort, and then we're going to use an evidence-based practice like CAMS. I like CAMS, Collaborative Assessment Management and Suicidology. I think that's the most accessible, easiest to implement. DBT is the gold standard for preventing suicide attempts and deaths, no doubt about it. But it's really hard to do that in an ED setting, and for most outpatient therapists, that's probably not feasible.
So I think that's a good point. Like, we know that inpatient care, it should be the last resort. We're looking at least restrictive care, right? I am thinking about, one, making sure that we're helping our clinicians who are viewing and helping them understand, like, how do you initiate a protocol within your practice, or if you're running a group, or if you're in an organization, like, what are the basic things that we need to help our clinicians know? And then does it differ based on different cultures that you're working with?
You know, one thing is interesting, if you talk to people with lived experience, who've been suicidal, who've been hospitalized, most of them were traumatized by it and did not find it helpful. So I think that's really important. So we do have to learn from everybody involved. And that's, you know, learning from people with lived experience is one of the places we get a lot of important information, right? So, and that's part of what I like about the CAMS approach too, the collaborative assessment and management of suicide that Dave Jobs developed, is because the idea is to keep people out of the hospital if at all possible. You know, we want to keep them alive, and sometimes the hospital can be important. I'm not trying to say that it never is, but that's, you know, if we can help people and teach them the skills to manage their own crises when they get into crises, you know, they feel empowered and they're going to do a lot better. And
well, I think about those in training and your experience. You mentioned, like, being in training and you hear your client is suicidal, and what are you trained on? 5150. If you even have rights. So, you know, most people who are being hospitalized, who do you call? The police department. If there's even, at least in California, there's such a I don't want to say backlog, but there's not enough emergency services to go out and do checks and whatnot. So the police are your first line of defense. So I'm wondering too, if you think that there are differences now in terms of doing these assessments using telehealth or telemedicine modalities. Do you feel like the assessment should look a little different?
If I can go back a little bit to what we were just talking about how
Sure.
It's a bad idea to hospitalize, and maybe that will lead into talking about these different modalities for avoiding things. So it's actually interesting. I'm 3 hours away from home right now in another part of California, and I've been doing trainings for emergency medicine docs and nurses all day today on different aspects of acute emergency psychiatric interventions. And we were talking a lot about the whole concept of least restrictive setting, and you know, it's a mind blower for them when you can see them get that aha moment where they're like, wow. Because what they're trained in the emergency department is, if somebody talks about suicide, the best thing we can do for them is put them in the hospital. That's their gold standard in their minds. Right. I agree with you all completely, like you were saying, Bart. I look for every reason to avoid hospitalization. There are times that it is the right thing, but most of the time it's not. And so how do we even get those people who aren't as, don't understand things as well, or maybe don't even have somebody who's knowledgeable about mental health working the ED? Maybe it is just emergency medicine doctors and nurses working there. They need to understand that concept of least restrictive alternative. And what if I explained to them in the trainings today is, well, you know, we all work in hospitals. Would you like it if, you know, at the end of your shift, you couldn't go home, but you were locked into the unit where you work in and you couldn't leave for the next 2 or 3 weeks? And how would you think about that? And so think, just like, obviously that's solipsistic, but just think about if it would be the best way that you think you could get help, is being locked in somewhere. And would it be different if you could be doing something home, free to come and go as you please, working together with somebody who understands what's going on with you? And that's why it's a so much better way approach. So many of the people that we work with, if you mention the psych hospital, they disappear. They get very scared. They frighten. They might turn off your telepsych interview or run out the side door and say, "I'm not doing that. I'm not," you know. And we've been seeing that forever. You mention the name of a hospital that they've been to before, and they're like, none of that. Yeah. So just to kind of reinforce what Bart and April were saying, and Lisa, it's there's a better way that we can work with these folks, and it's, again, training not just even the people we're talking about, therapists who maybe don't have a lot of alternatives, but to call 911 And what happens? That person gets brought to the ER, and then you've got an emergency medicine doc just going, suicide? Well, let's call up Joe's, hospital and gasoline, and we'll get them right over there right away.
And I just need to fill out a safety plan, set up an appointment for 6 weeks, and send them home because I have to get somebody in this bed who has an injury.
Right.
Because emergency departments, this is something that makes me specifically furious, which is that emergency department, emergency room care is not designed for mental health emergency. It's not designed at all for that. So it's designed to save your life in other ways if you're having a physical emergency. But we're putting folks at the wrong level of care. It's very expensive. It's traumatizing. And what we know, our data from the CDC that we have is consistent, even the old data, which is when we send people to hospitalization and we discharge them, we have a pretty high attempt and death rate in the first hours and 1 to 3 days. So it may be iatrogenic. When we hospitalize people, we may be increasing their suicide risk following discharge. And all of our evidence suggests that. So if someone it makes me feel safer and more virtuous, and probably my insurance loves it better if I do that, but it is not better practice.
So I think that's a really good point that you bring up, that your insurance probably likes it, because that is a number one reason that I have heard from supervisees and just folks that I've worked with, that they're sending people to the hospital. Liability, that is a big issue, and a lot of people are afraid of
Raise your
the
hand
liability.
if you've been in a malpractice lawsuit after doing really great suicide care for years and years, and did not send someone to the hospital, and made, by the way, the right call, and something still went wrong. Anybody? Yeah, it sucks. It really, really sucks, and it's not right. And so I spent almost all my time educating my lawyers and the other people's lawyers and the judge, years educating them about suicidology and good suicide care. Because I can tell you that your insurance company and your lawyer, like almost none of them understand suicide. And what we have taught everybody is you just call 911 and that will work. And I'm like, no.
Yeah.
So I'm curious if you guys can.
We've incentivized sending people to the hospital, right?
Right.
It's incentivized at every layer. And there's another thing about this. There's two components. One, while we provided less adequate training for suicide intervention to our clinicians, we hold them to a higher standard than we do heart doctors. Heart doctors don't get sued because someone has a heart attack. If a heart doctor sees somebody, identifies the risk, says, hey, this is what's going on, here's the appropriate treatment, we're going to start you on treatment, and that person has a heart attack, they do not get sued for that. The opposite happens in mental health. You identify a problem and need, you treat that need, and then the person does something, and because you failed to predict and prevent this event, which we really can't do in that way, you can get sued. So we've done a double whammy on our providers. We undertrained them, and we hold them to a ridiculous standard that is just out of control, and that has incentivized putting people in the hospital because everybody's afraid.
So since we're talking about this, and this is going to be novel information for many clinicians who have been trained, and myself included, and I even worked inpatient and was trained inpatient to say, like, people should come to the hospital first. How we're talking about this is, these are best practices, not to necessarily assume someone needs, to be 5150, but to hear them out, work with the individual, hear their experience, hear their concerns, and work with them to come up with a plan that is feasible. So I'm thinking about, for those clients who go on to complete a suicide, working with that clinician, how do you help that clinician understand what to do, how they should take care of themselves, what they should plan for if their client actually moves forward and completes a suicide? And I think Dr. Firestone, if you don't mind, I'm going to start with her. I want to make sure I get you in this conversation.
I think then you are in that role sort of playing defense, and because of what everybody was just saying, that we're held to a ridiculous standard. Even if your client was not cooperating with treatment that you were suggesting. I think the biggest thing is, there's going to be the practical implications of that, but it's also taking care of yourself, because that's a very painful loss for you personally. If you've been working with this person for a long time, you're going to go through all the same kind of reactions that family members go through who lose a loved one to suicide. And there's a lot of anger going around when there's been a suicide. Families want to blame clinicians want to blame families, and it's very hard because if somebody killed somebody you loved, you'd clearly be angry at the murderer. But when the murderer and the victim are the same person, it's really confusing. And suicide is a confusing kind of loss for clinicians as well as for family members and loved ones. And so, getting support for yourself around the feelings you'll be dealing with is important. And that's where I think, April, you mentioned clinicians who've lost clients to suicide as a support group. And you can access that through the American Association of Suicidology. And it's really important to talk to other clinicians who've gone through this. So there's whatever legal issues you have to deal with your insurance, because we are held to this ridiculous standard. But on the other hand, and I think we should all be practicing good care. There's plenty of people who are being held accountable who didn't do good care. I'm not saying that there aren't. There's plenty of people doing really lousy care out there, as Bart mentioned. I agree with you 100%. And that's why I'm glad we did pass a law in California and that people are getting more training. But if you look at what those trainings are, we didn't make any standards about what the trainings are. So, if Bart's doing it or April's doing it or Scott's doing it or, or if I'm doing it, we at least know what we're talking about or have, and have a deep investment in this field and the latest research. That's not true for a lot of people are saying, oh, what does it feel like to, they're talking about, just dealing with what it feels like to sit with somebody who's suicidal, which is important, but it's one piece of the puzzle. We need that with the research we do have, which is not enough, but we do have some empirically validated, approaches that do work.
I appreciate
with most people, not with everybody, and it depends, there's probably a graded level of care. CAMS probably is going to work with most people, but some people need DBT. Partly depends on their personality, but it also depends on other things, the level of severity, where they are in that continuum of being freaked out about feeling suicidal to feeling really comfortable with it. And that's a really different you're treating a very different situation there. So I think there's all these different treatments out there that we do know something about now. We do know something about safety planning or crisis response planning and people having the tools to try to manage their own crises so they don't end up in the emergency room where they're not necessarily they're probably going to get, treatment that's not going to be helpful to them necessarily, getting locked up.
So I'm
too scared to deal with this, so I'm going to put you in the hospital so I don't have to be afraid, which is not helpful for our patients.
Yeah. I think that's a really big piece of the puzzle. Clinicians being able to assess their own experience and feelings around clients talking about suicide and being a good container for it so that they're not trying to move them to the hospital. And I just want to do a quick recap for anyone who's just joining us and just share, it sounds like as of right now, main topics that we are putting on the table is thinking about good quality care, doing an appropriate risk assessment or risk needs check to determine what your client is actually in need of versus doing a quick check off and then sending them to a hospital if they are expressing suicidal ideation or a plan or intent, but really connecting with them and getting a sense of where they are on this continuum of their, I would say, readiness to complete a suicide or I'm moving away from attempt and commit, but trying to find the right words in the later afternoon can be really challenging. And then also we're looking at the importance of appropriate treatment. Hospitalization should be the least restrictive care, but often is the go-to. So we're just looking at making changes in terms of good clinical practice when it comes to suicidology. And so moving forward, I want to think about or have you guys speak to, let's stick with clinical care and supporting colleagues for just a little bit longer. You, Dr. Firestone, spoke to, and Dr. Foreman agreed with, connecting clinicians together who have lost patients and really leaning on each other to support each other if there is a loss. I want to think about that and also think about what type of legal issues should they be concerned with conducting such assessments of risk with telehealth. Because I'm sure that's probably a big conversation within those groups of supporting clients who are actively suicidal or have made or expressed attempts in the recent past. Dr. Foreman or Dr. Zeller, would you like to chime in on that?
You're on mute, April.
Yes, I cannot hear you. Nope. Excuse us 1 second. Dr. Foreman has a technical difficulty, but if Dr. Andrews or Dr. Firestone, if you have a thought, go for it.
I just want to say one more thing, which is I think one of the things that can help us do better clinical care and manage our feelings better when we're treating, clients is to get consultation. Like what you were talking about at the beginning, Bart, and, reaching out to people when you need help and leaning on people. It's a good idea because sometimes your anxiety gets in the way and you don't even do what you would normally do that you would think of with any other client. And I think it's really helpful to do consultation and get support and reach out to your colleagues and to the experts and get, they're out there and they will talk to you, and it's important. I think that's going to make for better clinical care.
Dr. Firestone is still right about this. That's why I really like being a part of a clinical team, having the ability to reach out and consult. I feel so bad for private practitioners who are out there on their own. It is so, thank you all for doing it. It is so hard. I will tell you, I love the safety of a team, and particularly doing suicide care like we do. Having a team is so important. And I just got consulted on national strategies for suicide and telehealth, right? So what do we do different? What do we think about? So when we talk about telehealth, though, things get really complicated because it's done so differently in so many different settings that there's all these different layers that you need to think about, right? If you're a clinician and you're on screen with somebody in your typical session, a lot of the things are going to be the same, but there are things that you really need to attend to. One, when someone is in your office and they're talking about suicide, they're in your space, you know where they are, right? So there's a level of safety there, and you can see them, you can smell them. In theory, you could touch them. So if you're remote from them, you're missing a lot of information. So it's really good to, when you're screening for suicide, also ask, have you done anything to hurt yourself? And this is particularly important on phone work. And I've been on many a crisis line phone call where it took a while to find out the person that had already overdosed. So better to ask that question earlier, because you're not going to notice it as much as if you're in a face-to-face session. The second thing is that you've got to have a backup procedure. Hey, we're doing this intense work. What if my sound goes out? Like with April, what if the bandwidth is slow? So you've got to have a backup situation in place, right? So, and two, this is really interesting. And just having gone through some work with a bunch of other folks, clinicians have bad habits. And what telehealth does is it's going to expand and magnify those bad habits, things that, don't you think? So I think one of the things that I see with our clinical work is I think we're too complacent and too comfortable. And in the office, it's bad as it is. And telehealth, that can become really problematic really fast. You've got to be in charge of your session. You've got to be in charge of your client. Like, people can't be eating or going to the bathroom or, I'm just running to the store while we're on the phone with each other. So you've really got to set some really firm limits about the care you're providing. Yes, this is more convenient, and I love telehealth. I think we're going to see that just bloom. But we really got firm limits. You've got to be in charge of that process, because you can't provide good clinical care when somebody's like, I got to take care of my dog, or my daughter needs something. So you don't have those things in session as much, right? So the other thing that I'm seeing or hearing about is that a lot of clinics that are doing telehealth, they are doing asynchronous screening, right? And so you've got to be really careful about this. I'm at the point where I'm saying, don't do asynchronous suicide screening, please. I think it's a really bad idea. So and I'm not even sure, and I'd love to hear Dr. Firestone and Dr. Zellis, but I'm not even sure about mental health screening asynchronous, but suicide in particular. Don't ask somebody some suicide questions and then you're not going to see them for hours. I think that's a really bad idea, right? So backup plans, making sure you're structuring your sessions, make sure you've set your expectations for your clients for when we're doing telehealth, really important.
You're back.
And then again, asking, making sure you're asking thoroughly and asking if they've done anything today to hurt themselves or attempt, and asking that question outright is a good idea.
Yeah, Bart, I agree with you completely about the asynchronous. it's only good if that you have no alternative but that. So that's okay to use, but you should have 100 things above that you'd prefer to use. But what's interesting is that like I was saying, how we've seen in this last year with broad acceptance of telehealth in general, is just a few years ago, everybody just scoffed at it. There's no way you could do any of this. It's not possible. When we first started doing emergency telepsychiatry, like I said, 20 years ago, people were saying, well, that's the one aspect of mental health that really can't be done over video. You know, we could see you doing a counseling, but not an assessment in an emergency department. So there's been so much of that idea that it can't be done. And so it's gratifying to see across the board how much we can do. I agree with you completely that it's a different arena and we have to understand that. And somebody might be distracted because the dog's barking in the background, or the husband just got home from work, or the kids are yelling, you know, all these different kind of things that can happen where you're in that pristine environment within your own psychotherapy office that there's almost a different dynamic there. And how can you kind of understand that? At the same time, it's a really cool thing that we actually can access this different environment, which was not accessible.
Yeah, there's pros and cons to it.
Right.
It can happen in our environments too, right? I mean, I have a big family, and while we've been isolated together. So, you know, there could be a baby crying in the background or something too. And I try to minimize that, but it can happen.
I think that's really important. One thing that I find to be a benefit of doing the telehealth is that you get a small glimpse into the lives that you don't see when you're in the, hour a week session. And I think also this experience kind of humanizes us and takes us off of this idyllic pedestal when I have my 2-year-old having a fit because she can't have my boba or wants to come downstairs and play. So I think that belief that there is a certain level of perfection, or that, our lives are absolutely perfect and there's never any problems, which I often hear, it's dispelled a bit. So I do think that there are benefits to being able to do the telehealth. And I think there are challenges in terms of once doing the screening and we're identifying that someone is suicidal actively, maybe has some intent, but no full plan. How would you handle having this plan for after you've gathered all this information and doing it in a telehealth kind of digital way? So how would you handle postvention to support clinicians in creating a plan? And Dr. Foreman, since you're back, do you want to hop in on that?
I have to say, and I'm hoping that I bet every one of our panelists has been a part of something like this. Where I was working at one of the hospitals I worked at, it was my job to help come up with the postvention plan. A couple of things that I recommend. Number one, if you're working in a system, I really recommend that you find 2 people. Anytime that there's a suicide death, you should definitely do really good sort of safety practices like root cause analysis and assessing what happened. And the system should do that. That's how a zero suicide, high safety, high reliability system works. And you should have someone else whose only job is to take care of the clinician, and who does not have that conflict of interest of having to look out for the system while being nice to the clinician. Because whether you as a clinician, I remember I was giving a presentation. Vanessa McGann is the AAS loss survivor chair, and she's a clinician loss survivor. And she, I was telling sort of one of my loss stories and what it was like to go through it. And she said, but you were really heavily reviewed, and your stories, you did everything like you were supposed to, like exceptionally well, and then have this situation. And she said, but what about clinicians who, I think Bart really pointed out, like the dilemma that we put people in, which is high accountability for something we can't predict, low training. What about the many people like that? And so having someone to support you is really helpful. When I was dealing, for example, with a lawsuit that went on and went on and went on, Bart, I called you, I called Skip Simpson, someone put me in touch with multiple people who had been there. because that's another little dirty secret, which is if you don't have your clients should never kill themselves, or it's all over, like, for you. And in fact, I had the experience of my colleagues treating me well, getting support. I think when I had an interesting trauma reaction to something from years ago, because I'm tired and fatigued and it's Suicide Prevention Month, like, I literally had Bart that I could call, like, who'd help me do a grounding exercise so I could just get back in my head and do a podcast. So, like, having someone who knows what's going to happen, can give you good advice, help you look out for yourself, help you, I don't know, Bart, Scott, Lisa, I would say contextualize what's happening, because you can catastrophize it, because your client killing themselves is, to most people who trained you, a scary, almost impossible fairy tale of an event that you'll just avoid by being lucky, right?
So I think that Zero Suicide, and if folks aren't familiar with Zero Suicide, the website is free, and there's so many tools on there, and there's great resources on there for post-suicide processes. There's some really key things that we've learned over the years. One, it's not the time immediately to do an investigation, right? Do not, right? The key thing, and we've learned this, is support your clinicians. Make sure that you are taking care and getting your emotional needs met, because we know that the grief factor is very real, but it's compounded because you have a sense of moral liability. And here's one of the things we haven't talked a lot about. People talk about legal liability, and people are afraid of legal liability, but I find the bigger driver is this moral sense of that I didn't do the right thing, or this person died because of me. I think that's a bigger fear than the legal. I think the legal's still big. Yeah. So helping the clinician ground and work through, because it's an intense experience. When you lose a patient to suicide, it hurts, and you might start feeling incompetent, or it's your fault. And so really good support. So one of the things that we do is, first thing we do is we debrief everybody that was involved, everybody that touched that patient in any way, right? You start with them. Make sure that you're focused on what they remember, how they're feeling, their self-care plan, what are they going to do? And you've got to have their backs. Your staff and clinicians need to feel like somebody's got their back. It's so important. And if you're, when we talk about a just culture, and Zero Suicide talks about a just culture, a part of a just culture is that if staff feel like that their bosses have their back, and they're gonna support them. It's so important to put our clinicians in such precarious places that they get that support. You should have, as April pointed out, you should have a review process. And the review process really should not be a fault-finding process. It's an understanding process. Let's understand what happened here, right? And so a lot of this is the culture and how we approach this thing that's happened. Now, when I reached out years ago after we had a suicide death and talked to some AS experts, we decided we have a very public approach at BHR. When we lose a client to suicide, we deal with it as an agency, right? We don't let, and what used to be often at clinics back in the day when I first started, a patient would die by suicide, and nobody but those involved would know about it. People would clamp down on it, right? We do do that. This is an agency-wide thing. We grieve agency-wide, support agency-wide. So those are some key things for me in terms of the immediate emotional support component.
Well, I just want to add really quickly April's point, like the person supporting the individual who lost the client should be someone who is removed from like the organizational responsibility, because I think too often, people who are in the highest position are also trying to support the clinician, but run the organization, and things get blurred. So I really do appreciate you adding that point of having someone there to just support the clinician. And it's great to take an organizational approach, but having that person who's slightly removed, I think is significant. Scott, please go back with your point.
People covering the back, like Bart was just mentioning. And you a little bit earlier in our discussion tonight, you brought up the idea of like nobody goes after a cardiologist when somebody dies of a heart attack. And yet suicide is basically our heart attacks and how awful that is. And probably every one of you on the panel here has been in something like a root cause analysis where somebody they start finger pointing. Well, if you'd done a better job, the person would still be alive today. You know, it's almost like that. And if that's the most destructive thing you could possibly come up with, this is the biggest risk for the kind of work that we do. And you need to be understanding and supportive and say, like, you know, it's probably going to happen to you at some point in your career if you see enough folks.
And I add to that? Go ahead.
I would say just like what you said, which is someone's going to do that. And I was so lucky to have clinicians around me, which I would say that is a really interesting attitude. What I'd love to talk about is like, what is your experience with suicidality? So what did you know about that? So would you say that, so like having even those wonderful Socratic questions to ask back, I have, because I know someone like Dr. Bart Andrews. I think Lisa's talking about the AAS clinician loss survivor group, and there are people that you can go to and say, hey, been there. This is not virgin territory. Someone may say this to you, and the good news is, here's what you can say back. I've had people sent to me who are like students. I know we've got students and peer leaders and things like that. And where a student was left with a really inappropriately complex case with a lot of risk and almost no consultation. And then like her educational career got totally like sidetracked, like in a way that like you take out loans for this or damage. And I was like, hold the phone. But no one had told the student, like, you should get some backup, because you have loan debt about this thing. You should not let folks treat you like that. It's really important for you to have professional colleagues have your back, because I promise you, and I think it's good, but your hospital or your clinic or whatever, or someone else's lawyers, they're taking care of them. It is important for you to have support.
Well, I'm just also thinking about the points that you made. This is a very big issue in our field, and it requires appropriate training. It requires the appropriate support of a team. And the experience to the clinician is this is the greatest loss or greatest challenge that they experience. I also find that clinicians will, like you said, go into this fear of, I should have done something better. I wish I could have done something more. And then that spirals into, are my other clients who are depressed or who are experiencing a lot of anxiety, are they going to kill themselves? Is there, more risk? Because if they're not doing something well, then how many people on their caseload are going there? So I'm curious about kind of the copycat theory and how to support clinicians in understanding what that means. And is that something that they should be concerned about?
Well, if you do process improvement without blame, that's a great way to start. Looking for things that you could have done better is not without finger pointing, saying you're an idiot, it's because of you this person passed. But saying like, maybe in this was a warning sign, maybe this was a red flag. This is things you could have done in a non-judgmental way. That's how you get people through these kind of things. And we all have colleagues who've done them, and that you can be very supportive. And it's like, nobody might have seen that, but if you saw that again in the future, here's what you might want to do. It's kind of simple.
I think that's great.
Like you agree, April?
I'm sorry, what?
You were asking
a question. Like you might agree. I saw you.
Oh, yeah. So zero suicide that Bart shared the information, like one of the whole elements is just culture, which is that many times clinicians are going to lose somebody to suicide. And when we haven't provided them with great science and high reliability or predictive assessments, and somebody does a pretty good standard of care, and sometimes even if they didn't do it perfectly, it might not have prevented death. And so we can always improve our care. And often there are system improvements. I think we've been telling the story that clinician heroes are what prevent suicide. I'm here to tell you it's high reliability systems. It's not great pilots, it's wonderful checklists that make your plane land safely. Same thing with suicide care. And so like you might have an RCA, and the RCA should not be a witch hunt about if that clinician was only more perfect, then no one would die. There's no scientific evidence for that. It should be like, well, we did not add asking about access to firearm in every suicide risk assessment and safety plan. And we didn't teach people how to talk about firearms, and PS clinicians hate firearms. So half of them don't even, our clients have guns, but our clinicians don't. So that's a real problem. So we can add that into every suicide risk assessment. We can add that into every safety plan. We can get our clinicians a lot more familiar with firearms. Well, that is something that has a shot at saving a life.
Mm-hmm. So I'm going to throw this out there. I'm curious about your thoughts. I'm sure you're all aware of the show on Netflix that came out about the teen suicide.
Is that the show that must not be named?
I'm going
It
to
has a number
assume
13 or
so.
something.
Yeah,
because I got to write the PSA script. I got to write the PSA script for season 2 for the show that would not be named. So like in 15 minutes, I write the PSA script.
It's not Voldemort. It's a stupid TV show.
Well, rights and things
I'm going
like
to steal that
that.
line, Bart. Thank you.
So
Yes.
let's talk about the show. Which study do you want to talk about? The study that found no impact, the study that found an impact among young boys, or the one that found an impact among girls, or my personal study that says we don't know what the hell we're talking about with media effect and suicide, and you can find a study to support whatever it is you want. How about that?
Go
Well,
figure.
there's definitely a lot of reaction to it, and I'm wondering if the one thing I think was really impactful is the amount of discussion that took place following it. And I'm wondering what you guys thought were positives about the discussion, or positives about even having this topic be part of discussion or the mainstream discussion, or what was some negatives.
Can we talk about a show that got it right? Can we talk about a main network show that just got it right a few months ago?
Sure.
Because I'm going to use this as a comparison. So
Okay,
has anybody, we got a lot of folks in the events. Has anybody seen SWAT? It's a cop
The old
drama.
SWAT or the new SWAT? The show or the movie? Because there's a show and there's a movie.
It's like the TV show. It's like go
The
to
show.
SWAT writers' room. Go to tweet them right now.
Okay.
Tweet the writers' room. So we were so lucky to get to talk with one of the producers from SWAT, and they had actually been incredibly interested in the issue of suicide because that's the leading cause of death for people in law enforcement. And they did a bunch of research. So they did something that writers really should always do and often don't, is that they really, the Writers Guild, you can access subject matter experts. So they accessed suicidologists, people understood law enforcement officer suicide. They wrote an incredibly well done, educational, accurate, and deeply entertaining show that was about the suicidality and suicide attempt of one of their team members. And if you want to, I mean, not everybody wants to watch that for entertainment, but if you want to see somebody do it really right, you can. Rachel Bloom, my crazy ex-girlfriend.
Mm-hmm.
Same deal. We got to do a cool deal with her. And she talks about going and asking about borderline personality disorder and asking about suicide risk, and making sure that when she writes and produces content, that they really talk with experts and do it well, so that their job is to be the talent and do incredibly good media. And you can always ask subject matter experts before you did that. Would I have loved for 13 Reasons Why to have done a little bit more of that before some of those opening scenes? Absolutely. But I think there are people trying to do it right in this media landscape now, and probably 13 Reasons Why, what happened after that, is a reason why people are being more conscientious.
Didn't they reach out to AAS for the second season? Were you guys involved with that?
Oh yeah, wrote the PSA about that, because they were like, dude. And I here's the deal. If somebody's going to create media, I'm going to talk to you, because I promise you, more people watch Netflix than talk to Dr. Foreman.
Well, seeing as, the show created a lot of conversation, and the SWAT episode created a lot of conversation, I'm curious what you guys feel have been some of the more pressing comments or questions that you've received from either the general public or from clinicians who have been approached, or this has been a topic for them. What are some of the things you're hearing people ask about?
I mean, did anybody else have kids who watched it?
Yeah, I mean, I think the biggest thing, and I'm by and large, I think the reaction, I was disappointed and I thought it was horrible. I think the biggest thing that I saw was a bunch of people that should know better saying that we need to shut this sort of thing down and censor it. And in fact, following that, Tumblr shut down self-harming posts on Tumblr. So we've got this idea that we can make people safer by controlling media and being censorious. I think that that's unconscionable. I think it's bound to backfire, and it sends all kinds of horrible messages. So I think one of the things that people don't realize is we have really good things we could do to prevent suicide. improving care in healthcare systems. And instead, we've got all these professionals yelling about media. Here's why I think that is, and nobody's going to like this, because they can point the finger at somebody else instead of dealing with what they can be doing themselves to prevent suicide. So it's a nice, convenient scapegoat to focus on 13 reasons why, or the news reporting people's suicide, instead of saying, what are you doing in your system to prevent suicide? No, let's talk about what's on the news or what's on social media. I think it's a big smoke screen. And I think that too, where at April I disagree. If you're an artist and you're creating, you create.
Right,
the idea you somehow have to research this thing. So what? How would we have Lord of the Rings? We're going to research elves. So I think that for me, the creative element is people are going to do what they're going to do, and they're going to create art. And then it's our job then to support people to this whole idea of like trigger warnings. I don't know if you've seen the data on trigger warnings, but trigger warnings actually increase anxiety responses. They don't decrease it. But we buy into all of these cultural memes about making things safer, and we do the opposite. We make people less safe in the process.
So I want to get to Dr. Firestone, because it looks like you had a comment too, and I want to make sure you have space too.
Oh, I mean, yes. I think it was done horribly, and I think it wasn't a good message, but I don't think it's the main thing that's causing suicide. And in that way, I do agree with you, Bart, that, we have to do good clinical care. We can't blame it on a TV show, but because I think the kids who can get influenced, or people who can get influenced by media, are people who are in the zone. It's not people who are not. It's not like perfectly well-adjusted, healthy young people or adults are going to die by suicide because they watched a TV show. But that I really don't believe. And I don't believe we can blame it on them. Would I rather that they did responsible job of it, or a good job of it? Yeah, I do. And even though they're artists and they get to create whatever they want, that's the way I feel about it. But I don't think it's the main issue driving, suicide, or the main thing we could do as clinicians. The main thing we can do as clinicians is provide good care.
Well,
I think the one thing that it does is that we have to keep an eye out for, and it's part of the whole, going back to the early suicide screening evaluations concept, is that things like this show and some of the other things that come out in popular culture is a validation of the ideas that suicide might be an option. And that's something that we need to be careful about. Not that this particular show is going to convince anybody that they should kill themselves, but that there's a normalization of it. And that if you hear somebody having those kind of ideas, like, it goes beyond pop culture, in that as part of any standard good suicide screening is talking about family history. And if you had an uncle who killed themselves, there might be in the back of your mind this idea that maybe that's an okay thing because Uncle Charlie did that, so maybe it's not such a bad thing. I don't have anything against any of these artists doing what they will. I think what Bart, Lisa, and April all said was exactly on target. I just think that it leads to, if you hear those things mentioned, that should be a little bit of a red flag for you. In like, why is that important to you? Or why was it okay that Uncle Charlie killed himself? And just use it as part of your screening, not to condemn any part of it overall. I don't know if that makes any sense.
I think we have a lot of moral panic. Dungeons and Dragons was supposed to cause suicide in the 1980s when I was coming up, right? Mm-hmm. I think we need to remember that suicide's been a leading cause of death for a long time. It's been a leading cause of death for kids for a long time. Suicide has been in our media as long as we've had media, right? Because we're talking about things that happen to people. And we're holding the media way more responsible than, in fact, than the American Psychological Association holds our clinicians or training programs. So while I want people to be more responsible, why don't we just hold our licensed providers more responsible just to start? And then we'll work our way down to folks. But in the meantime, folks will ask, I've been asked like recently about TikTok. I've been asked about, Tumblr. We get asked about 13 Reasons Why. We get asked about the Momo Challenge. We get asked about all this stuff. And there are some real practical things that parents can do. So if we're worried about kids, then we can do way better screening and assessment. We can do way better means restriction in our homes. So we need to educate parents about means restriction in their homes. And we can educate parents about how to manage all of these resources that kids have in ways that we can understand when they're using them, where they're going, and as opposed to they just either take the phone away, which is crazy, or give them unfettered access to the world, which is also crazy. We could be doing so much more to help parents and to help clinicians and to require people to know how to handle this. And I would love for us to not worry about Netflix so much and worry more about parents and clinicians.
I think it's a really valid point. And at the same time, I'm wondering about families who are doing so much right now and just trying to stay sane for themselves and manage so much. It sometimes feels like it's an extra task of like staying up on all of the latest. And even as myself as a clinician who works with adolescents and children, like knowing all of the new apps, knowing and having access to and being aware of, so I think you have to stay up on it, but I'm wondering, how do we help families do it in a way?
Couple things, real basic things that you don't have to learn too much. I would say, number one, we should teach parents how to manage the settings of their home Wi-Fi and internet. Almost all of them have them, about how much bandwidth you give somebody and how much the equipment in your home, that like it's real easy and you don't have to know how to manage an app or stay current on a platform. Like I could give my kids access at certain times and I could do it by device and I could know which devices we're on. I similarly use a bunch of control settings on my cell phone carrier. It's a $5 a month plan. They're really basic things that I can do, and I can dial up or dial down how much access my kid has digitally and when they have it. And that includes throttling the bandwidth down so low that a whole bunch of stuff that you wouldn't want your kid to get at certain ages or risk levels they can't get. These are pretty basic things. And you might be able to then, you can adjust based on the health of the child or the age of the child or the development of the child. Why we haven't educated parents about that, but I got to have somebody install my car seat? I don't know.
Well, I think we're talking a little bit about like the fast pace of technology as well as just the amount of information that's available. And sometimes it gets out faster than I think parents, adults, just people can stay ahead of. And then what you catch can, what I think taps into is this fear of influence, or, the myth that if you talk about suicide or you watch, shows about suicide, then it leads to more attempts. And I want to kind of just jump back to clinicians as well. I think part of a concern or a part of a reason why maybe we haven't had as many resources put into training for suicidology is the amount of work that people think it's going to take if they have a suicidal client. So checking in with the client, checking in with family, doing all these extra steps. I think a lot of people believe that it's just going to take so much work. So let's just put them in the hospital. I'm wondering if you guys could speak to that. Like, do you really, in your experience, see that it takes all those additional hours?
It does take work. The billing codes are crap, and that's not fair or right.
So let's get to the heart of the issue, right? We love paying for fancy blood tests and medical exams. Anything that has a procedure where somebody else can make a ton of money on it, we fund the heck out of it, right? We don't fund FaceTime, right? So when you look at fields that are predominantly human-to-human talk intervention, and even in medicine, the more FaceTime you spend with people, the less you make, right? So we have a whole medical system that's geared to reinforce certain things. We don't have suicide-specific codes. We really need a suicide-specific diagnosis. One of the huge challenges we have is right now, you go and you get treatment, you get diagnosed with depression, so you treat depression. You need a suicide diagnosis so you force the clinician to actually treat the suicide, not the underlying depression. You may do both, right? We've got no good evidence that treating just the underlying condition is suicide preventive in any way, shape, or form. By and large, there's no exceptions to that. There's a huge funding gap in terms of what we spend our healthcare dollars on. Behavioral health, interestingly enough, was one of the smallest pieces of the pie, and the first thing that managed care did when they got their hands on our healthcare dollars was completely trash behavioral health, right? Because we have the weakest lobby and the weakest political influence, right? So here's this, I don't care what people say when I say this, I want suicide prevention experts that make damn good money. I want them to be paid really well, and I want people to be able to come in and have that time reimbursed at a really high level, just like we do with heart care, just like we do with cancer care. And one of the biggest, and April will back me up on this, just in federal research dollars, we spend about $70 million a year on suicide prevention, maybe 80. The next closest cause of death is like in the 700-800 million category. The disparity in money that we direct to suicide prevention is ridiculous. And so, of course, you've got clinicians that are underpaid, overworked, and we don't fund the suicide prevention system in a meaningful way, and people keep dying. Big shocker.
Yeah, you know what, Bart? I couldn't agree with you more. I'm 100% on board with you. And sometimes I wonder how much our general mental health spectrum propagates that, because there's so many people in mental health saying like, no, we don't want that integration with medicine. That medicine is icky. They're over there. Mental health is over here. So we're not part of that. And then we shouldn't be, don't reimburse us the same way because we're special. And so whenever you do that, you're going to get less reimbursement. You're going to get all these other things. I find it very frustrating. The brain is part of the body too.
And I would say we have all these mental health providers being so incredibly humble and like, maybe I can take less. And I'm like, oh, honey, please. Like, no. Like, yes. Do you understand like how long it took to produce you? We think of therapists as if they're primary care doctors, which is sort of true, but therapists are often like the aspirin, or they're like the medication, the life-saving medication. And it takes years and hundreds of thousands of dollars to make a good therapist. And then you don't bill for it? Oh, please.
And you minimize what you're doing. And it's actually amazing that you got to this point and you can do what you do. And it's not like, oh, anybody could have recognized that. No, it's because you're so well trained and you've spent those years and years. Don't minimize what you're doing. You are our conduit to giving people great mental care.
Well, I think we have to dispel the myth of what care actually means. It's not just we're doing this because we have warm and fuzzies and we just want to be out there caring about everyone. We are trained clinicians with a specialized skill to provide a certain level of care, and we practice within our scope. So we need to make sure that we're appropriately trained to provide this support for clients who are suicidal, actively suicidal, and put in the work. And it would be great to be reimbursed for it, but often that isn't the case. So, we're working within our confines and doing the best that we can. And I really just want to appreciate everyone and your thoughts and just the conversation that we've had thus far, because it's been absolutely amazing. With the time that we have left, I would love for you guys to share your most important takeaways. Like, what are some things that you feel you want to make sure that our viewership is taking away from today's discussion? And if we can start with Dr. Zeller, what would you say?
There's a really important thing, and I think it's just what we were just touching on, and that is how important working with suicidal individuals is, and that it is a medical emergency. And I don't know that a lot of people understand that when somebody comes to the ER in the USA, there's this law called EMTALA. Most of you probably have heard of it. It's the Emergency Medical Transfer Active Labor Act. Basically, it's the law that says, and you hear about this talk sometimes, that if you come to the ER, they have to evaluate you. They have to treat you regardless of the ability to pay. And they have to evaluate if you have an emergency medical condition. What I think the average person doesn't know, and perhaps some folks in our audience might not know, is that psychiatric emergencies, especially suicidality or anything involved with suicide, is considered a medical emergency. The same thing as if you're having a heart attack, or you're short of breath, or you've been in a car accident, a trauma, anything like that. A psychiatric emergency is a medical emergency. So anybody going to an ER, it's the same level of care required, the same level of scrutiny, the same level of evaluation, diagnosis, and treatment. And they can't discharge you until you are no longer considered to be a danger to yourself or others, basically. So recognizing that, it goes back to our discussion from just a few minutes ago. These are medical conditions when somebody gets so severely impaired that they become dangerous to others, or more importantly, for our conversation today, dangerous to themselves. So it needs to be reimbursed that way. That if you're helping to prevent somebody from causing severe harm to themselves or killing themselves, that is a medical procedure that needs to be compensated in that exact way. And already the federal laws recognize suicidality as just as big a deal, as just as dangerous as any other emergency medical condition you should die for. And the more we're able to recognize that, and the more we're able to pass that along to our colleagues and say, there is a way we can drop suicide from being the 9th or 10th most common cause of death down to, let's go for 24th or 25th or something like that. And it means intervening in such a way that this is important. This is not just, oh, whatever, they why don't they get a job or talk to their priest or something like that. These are serious conditions, and our trained professionals that are on this call are more than qualified to work with these folks, and they should be compensated appropriately.
Awesome. How about for you, Dr. Firestone? What would be something that you feel is an important takeaway for our viewership?
Yeah, if for clinicians, your viewership is people to really think about their own feelings around this issue and their, how do they respond to people who are struggling with these things, and can they really be present with it, and deal with their own feelings around it, because we want people to get that good care. You are in a life-threatening situation, and I don't think that's why most people go into this field. People think, oh, I want to help people. They don't think I'm going to be dealing with life and death, and you are at times. And your ability to really be present and to bring good clinical care at those times can save lives. So get the training that you need to feel really comfortable, deal with your own feelings around it, get consultation and support, and really, try to be really there and present for people in a way where you're really trying to understand them and how they got to be there, to a point where death seems like the solution, and how can you help them find their way out, and being willing to be on that journey with somebody and, go through, deal with whatever feelings come up for yourself.
Awesome. And how about for you, Dr. Andrews?
Yeah, so I think the level of agreement, you can see that people that care about this issue and are informed about this issue, there's a good consensus, right? And that's really encouraging to me that we're really seeing that people are getting together on this. For the folks paying attention, if I was going to give you one piece to take away, go to the Zero Suicide website. It's a wonderful free resource. April talked about high reliability systems. This is one that helps you create a high reliability system for suicide prevention. There's tons of great stuff in there. So if you want a real quick place to go to get a lot of detail about things that you can do to make even small changes in suicide care that you're providing, it's a great place to start.
Awesome, thank you. And Dr. Foreman?
I have two closing thoughts, and one that I really didn't talk about enough. It's feeling bad doesn't kill you. It's the thing that you use to kill yourself with that kills you. Often for a lot of my folks and across the US, it's firearms, for example. If you did literally nothing else, and I mean literally nothing else, bottom basement, get yourself some lethal means education. You can get calm training, which are conversations. I think, is it conversations, or what is it about lethal means?
Counseling on access to lethal means, and it's available for free on the Suicide Prevention Resource Center website and on the Zero Suicide website.
If you want people to not die, suicidal crises are very brief, and if you want people to not die, pretty much you just have to teach people how to be safe during these very high-risk periods. For many people in the U.S., that means firearms. Learn about guns, learn how to talk about guns. You will save real lives doing it, and it is incredibly concrete and practical. Like, if I could tell you nothing else, and I'm sorry I didn't talk about it. Bart, can you put calm in the chat box, and maybe really, truly, it's great. I know the folks who develop and keep that, they do God's work. Go take it for free, make everyone in your organization take it for free. Go to the shooting range and learn something about a firearm. So when you talk with someone who owns one, you can talk and not sound like a jerk. Do that. And the second thing,
not sound like you're coming to take their guns away. You just want them to be safe and prevent suicide.
Dude, I have an AR-15. Guns are fine. I lived in Texas, but what I'm telling you is, you as a clinician, if you want to help folks, you need to understand about lethal means, about medication, about lethal means, about hanging or asphyxiation, which are much harder, right? Look at your point, hanging. There's only so many ways that people die. You could just educate yourself about a couple and probably save your patient's life. Now, the second thing I'm going to say is this, and I think this is a good note to wrap up on. This is incredibly hard work. Do not do it alone. I do not ever do this by myself. I go with friends. These are some wonderful people here. I think Lisa Firestone is really trying to tell you where all those resources are. Don't think that you can take one webinar and you've got this. Like, no one's got it like that. When I do high risk care, I've never done it by myself with someone. And can I tell you, that doesn't just to protect my client, that takes care of me. Make friends, do this collaboratively, get support. I think we are so much stronger as a group than we ever are by ourselves.
I appreciate that. And I think one thing that I want to add, which was brought up to us with Dr. Firestone's earlier experience, if you are supervising or working with students, trainees, interns, check in with them as well. Because the one thing that I hear about not only camaraderie, but just making sure that we're talking about it, because it's easy to assume that someone is, or they're comfortable addressing these topics, and they might not be. So I just thank you all for all of the amazing content. I realize the sun is setting, so it's starting to get dark in my house. So I appreciate everything that you have all shared. And I imagine that some of this information has been new for some of you, but definitely look into the resources that are posted in the chat, and definitely take care of yourself. And with that, I will bid everyone adieu. Thank you again so much, Dr. Zeller, Dr. Foreman, Dr. Andrews, and Dr. Firestone, for your time. You're doing amazing work, and it's so appreciated.
Thank you all.
Thank you.
Wonderful.
Thanks. Yeah.
All right, and I can't get to my light, so I just want to say thank you all for joining us. This has been another amazing TogetherWell event, and I do hope that each of you have been able to take some really helpful, useful tips. There are plenty of resources that are available in the chats and will be made available after the talk has been posted. Just want to remind everyone that there are and will be the meditation after this talk, and that you should definitely make use of it if some of the topic or some of the information was definitely triggering. I do hope that you were able to take away information that will help you think about creating a healthy suicide risk assessment for your practice or your group or organization. And then also just want to let you know our upcoming events through TogetherWell will be posted, but we are going to be doing a series called Together with Dr. Helen Sue, who's a Stanford psychologist. She's going to be interviewing Dr. Ramani about cultural gaslighting, and so that's going to be an amazing talk. We'll also be doing our next Third Thursday event for therapists in October on the opioid epidemic. And we're also going to be looking at doing this work, addiction treatment, with telehealth. So that's going to be another amazing opportunity. Also, if you're wanting to further discussion and participate in other discussions, please join the TogetherWell Facebook group for therapists. This will be posted there with other resources. And give me 1 second because it's just really dark. Sorry about that. And then lastly, I just want to make sure that we mention that TogetherWell is looking for more facilitators to join the nonprofit. So if you are interested in participating in trainings or hosting or things like that nature, go to the website so that you can learn more. And that concludes our discussion for today. Please stay on for the 15-minute mindfulness session that will take place shortly after this. Networking, if you again, are interested in connecting with folks who can become your support if you're doing work with suicide, actively suicidal clients, or want to learn more about creating your own support network. Definitely reach out to folks who are in that chat. Without that, I will bid you all adieu and have a wonderful evening. And until next time, take care.